So for prenatal care, there's certain things you have to know. So we'll start like a folate. Anybody who want to get pregnant, you know what to do. You're supposed to get like at least 400 to 800 milligram of folate per day before you have to get pregnant. If you don't do that, you get a neurotube defect, which is really bad problem. So we want to make sure we taking care of this problem. There's some medications that can also cause this defect because they decrease the level of folate, like the seizure medication, valproic acid. Those medication, the reason why they causes this problem is because they decrease the level of folate in the system, and that's the reason why. So anybody who want to get pregnant, they should do that. And what do you tell them to do? Yeah, they should get the source of folate. It's fortified grains. It's very, very good. Or green leafy vegetables is very, very good. You can teach them, like broccoli is good. They should start eating that, and the spinach, even though it has oxalate in it, is very good. And green peas. These are all sorts of, there's a bunch of them, the cereal fortified with the folate, and some pasta, some rice. And so whoever want to get pregnant, you got to do that, start eating that. And peanut butter is very good source of folate. All of them have different concentration. Some have like 800 milligrams, especially peanut butter is very high level of folate level. And then rice and fortified cereal, very high, like they can go all the way 800 milligrams. And you tell them no alcohol, right? That one is no brainer. So you shouldn't drink if you want to get pregnant, no tobacco. Problem with placenta abruption, ischemia, alcohol fetal syndrome is not good. Then you got to check their rubella status. It's very, very important. So we got to check your titer. Why? I mean, if it's positive, the kid will have a problem. And so we want to check your titer before that. If you check that they come in, they're already pregnant, and you check their titer, and it was negative, well, then you have to, if it's negative, then wait after delivery. But if they're not, it's negative and they're not pregnant, yeah, then you give it to them. But what? Very, very important. Let them wait for 4 weeks before they get pregnant, because it's a live vaccine, 4 weeks before getting pregnant. When they're pregnant, well, you have to wait and give it to them as soon as they have the baby. But then if they're negative and if they're not pregnant, they're planning, you can give it to them and then we let them wait for 4 weeks. And then you got to avoid these medications, and you have to know them by heart, okay? They are teratogens. I want you to like have them at your fingernails, like you can remember them when you see them. These seizure medications, they are not good. Phenotines, yeah, they are teratogen. Valproic acid, like I said earlier on, they are not good because of the problem they cause the baby. Then Accreta, isotretinoin, that's the another name. This is for acne. Yeah, you can't have it. If the pregnant lady is on this, you got to, it's a B-sharp woman. You got to tell them, no, you can't have it. It causes a problem to your problem. Methotrexate is abortogenic. It will cause the baby to be born when it's not due time. ACE inhibitors and the ARB, they always friend. They can't have it. And warfarin. These are medication. I want you to like, if they give you OB question or pharmacology, I mean, these are like easy question. You should not let them give it, take the point away. These are our teratogens. A pregnant lady cannot be on it. These two will causes neural tube defect. Okay, these two, methotrexate abortion. This will cause a facial defect. These are renal ACE inhibitor affect your kidney, so renal defect. And if they have DVT, this is the question. That's the question would be: a pregnant lady has a DVT, and they need to go home with some medication. You cannot put them on warfarin, Coumadin. You give them heparin, and they when ready to go, you transition to the factor 10 inhibitors. Those are the one with the Zabans at the end of it, or Gatobans, like a Pixibans. Don't forget this. They cannot take Coumadin. You start them on heparin, and if their PTT is fine, you transition them to these Zabans and Gatobans. Okay. And then this medication, I don't like it, but we pop it like a candy. ACE inhibitor, NSAIDs, it affects anything in the system that you can think of. Anything, any organ in the body, NSAIDs are bad for it. But we need it, so it doesn't mean you shouldn't take it, but you got to have moderation. It can cause ulcer, it can cause heart problem, it can cause stroke, it can cause basically ischemia, it can cause renal problem. And so pregnant lady should not take it. That's not true. It's incomplete. I intentionally say that. They can take it, but at the third trimester, no, you cannot take it anymore. Why? Because it's an NSAID. And then what is the problem? There's something we call PDA, pectoral ductus arteriosus. Okay, PDA. This is what the baby is using to get oxygenation, blood from the mother. Okay, and so this will be closed by NSAID. If you take NSAID at the third trimester, the baby will have his PDA closed, and the baby will have ischemia. It will become a problem. So you should not take it. PDA get closed by NSAID. And so when it's open, as soon as you get born and you take your initial breath, the PDA will close. It will close on its own. If it doesn't close, guess what? We give you NSAID. And the NSAID we give you is endomethacin. And this is what you use to close the PDA. And that if it doesn't close, that's why we call it the PDA. So the actual name is ductus arteriosus. If it doesn't close, it becomes patent ductus arteriosus. So when a baby is born, their ductus arteriosus is open. But when they take a breath, it will close. After a couple of weeks, 1-2 weeks, and it's supposed to close right away. If it doesn't close, we call it patent ductus arteriosus. That's the PDA. And in your test, they will describe it as machinery mama. That's all. That's the way to recognize it. If it doesn't close, we give you NSAID, endomethacin. Because of that, when the mommy has is 3 in the third trimester, we don't want them to take NSAID, because if they do, they prematurely close the ductus arteriosus and the kid will not do well. That's the reason why. So that's the point you should know. So this slide, you see, is busy, but there's a lot of like testable information. I will encourage you to remember that. So it look busy. You should remember that. Okay. Okay. Yeah. Machinery mama, that's PDA. If they ask you what medication you give them, is NSAID. If they don't list it, it's endomethacin. If they don't have the name there, remember them. Otherwise, just choose anything that is an NSAID. So, but that will do that. Because of that, mommy should not take any NSAID at the third trimester. There's a few other stuff you have to know. This is, like I said, brief information. Touch. These are problems you need to tell the mother, stay away from this touch. Don't touch it. I call them touch, don't touch. They are touched, but you can't touch them because when you touch them, you get into trouble and the baby get trouble. Even though they call touch, it's designed not to touch them. So the T is toxoplasmosis. Stay away from toxoplasmosis. And you get it from the cat dungeons, like cat doodles, you know. Yeah, the feces, you stay away from it. That's where they have it. It doesn't mean you cannot have cat either, or cat leader. Somebody say cat leader. Yeah. Yes, if the mommy is on phenotime before pregnancy, you have to double the dose because the phenotime is going to chew all the folate. So we got to like increase your folate level so that it doesn't cause the problem. You know, so yeah, somebody is asking. Yeah, you want to increase your folate because it will be a problem. O is the other diseases. So other diseases like syphilis. Anybody who have this problem, which can cause a congenital problem with the kid, and then varicella and a parvo B virus, B12. This they like asking, and you think it is lupus. It's not lupus. The way it present in kids, and they have slap cheek. So if this is their face and this is their nose, they have slap cheek. Here, there's a rash here, and here there's a rash here. It never crossed the bridge of the nose. So don't the nose. And that's why it's a butterfly. The butterfly here, it crosses these people, they never crosses it. So they have just a slap cheek. And that's the parvovirus B12 disease. It's also very teratogenic to the baby. So mommy should stay away from them. So a pregnant lady and then somebody with the parvo B12 infection should stay away from them, or varicella. They can't take care of them. The same thing as rubella. And the C is a CMV infection, okay? And the H is a herpes. So those are the disease process the mother should stay away from it as much as possible. If there's an active, okay, if there's an active infection, mother has active vesicles from herpes, well, what do you think? There's no vaginal. We can't have vaginal delivery. No, you got to go through C-section. Otherwise, the baby get meningitis from it. So if they give you a question, if there's an active disease in the vaginal canal, we can't allow the baby to pass there. No, no traffic there. Traffic is jammed. We got to take another route. And we are gonna go C-section to help with the mommy. So the CMV is a cytomegalovirus, also very important. So these are diseases. It causes diarrhea. And so, like I said, they are touches, but you can't touch them because it causes teratogenic problem. Is what you already know. Okay, based on that, they should avoid unpasteurized milk because it has listeria on it. This is the last group of things you got to tell the mommy to avoid it. This is for listeria. This is another problem that it makes them immunocompromised. So all the things I'm going to say is because pregnancy is dangerous. Okay. So pregnancy, I see pregnancy like somebody who's getting chemotherapy. Okay. So everything chemotherapy people do, you can apply to that. So you make them immunocompromised because of the baby. So you have a baby inside, your body doesn't want to reject it. And so your immune system goes down in order to support the kid. And so they cannot eat unpasteurized milk, anything like that. You will have listeria in it. If you want to eat fresh vegetables, no. You got to unwashed vegetables, you should stay away from it. It has to be really cooked and really well. You can't eat it at all. Fresh vegetables is bad. Okay. And the hot dogs, you can't go to the hot dog stand and go eat there. No, raw fish, no way. You get sick, and meat. So you can't eat your sushis. So, and then like I said, stay away from the cat litter. We know what happened there, toxoplasmosis. And they should stay away fish with high mercury. These are all no good for the baby. Which one would it be? Like the shark, like those are the swordfish, I call them the shark and the swordfish and the mercury. Those are all have high level of mercury. So these are like facts. If they ask you, they usually put it in and say which of the following you should intervene. Then you got to intervene right away. Then the vaccination they should avoid is those MMR, measles, mumps, rubella. Those are live vaccine, but there's few ones people get confused. Okay, varicella is one of them. And the flu vaccine, okay, flu vaccine. But which one? That's a trap question. Flu vaccine is the nasal one, the spray, okay, the nasal spray one. So they can get a regular one, but the one that they cannot take the inhale flu vaccine, even though it's always better. I would like to, I don't want to be poked. Yeah, you can't get that one. So that's the one as a live vaccine in it. So we should know that mommy do that. Okay. The rotavirus is also in the yellow fever. And polio. The polio is the oral one. Unfortunately, that's what they usually send to third world country. And it causes problem because it's cheaper, but nobody wants to send a vaccination, a lot of bottle vaccination that is more expensive. So this is what we have in third world countries, a polio vaccine, the oral one that is more teratogenic. It causes problem, but it prevents a lot of stuff. So oral one, yeah, you can't get it. You can get an IV one, an IM one, but not the oral form of it. So that's the first portion of it. You describe the word quickening. It's a perception of movement. So it's not a true movement, perception of movement, and that occurs 16 to 20 weeks. So you give you a lot of set of questions and they say which one is true. Yeah. The mommy is supposed to feel like the baby is there, but they don't know truly between 16 to 20 weeks. Okay. When do you hear the fetal? You can see the anatomy, the whole thing. Yeah, the fetal anatomy is usually 18 to 20 weeks. And then how many movements do they need to expect? 10 kicks in 2 hours. That is the average. And if there's no movement in 12 hours, yeah, you got to call the doctor. If they don't feel any baby for 12 hours, you call. Supposed to feel like 10 kicks every 2 hours. And when does the baby active? Yeah, that's something you should know. After you eat, because they know you're eating, they want some. So eating time, yeah, baby more active. They're more active at this stage. So they will kick you more. They will kick you after you eat, and that's when they kick you most of the time. Okay, so that's the quick first portion. Now that we know that some of the facts of pregnancy, we have to know who is actually pregnant. How do we diagnose pregnancy? Your test, they want you to know if it's a presumptive problem or whether it's a probable problem or whether it's a positive, true pregnancy. And I try to divide it like that easily so that you don't memorize stuff. But look at it. I call it subjective, which is the same. So subjective is your presumptive. And subjective is you, the mother. So how does the mother know she's pregnant? Well, she will describe to you, I think I feel this way. I think my breast is bigger, my breast is bigger. Enlargement. Yeah. I feel nauseated. I usually don't feel, I feel like I want to vomit. I need some spicy food. I'm tired all the time. I feel like there's something quickening, something is moving, but I'm not sure if it's there. Those are all what they telling you, what they think. So it's subjective. So this is the matter telling you, subjective. The probable is, think about it. If it's not subjective, then it got to be objective. That's why when you do physical, you ask subjective. No matter the patient will talk to you, then you do objective. You use data to tell you, right? So probable is an objective. That means you collecting information. This is not you, the patient, anymore. This is by MD. This is an MD looking at it, and it said, I think you're pregnant. I think you're pregnant. And the best way they do it, what do you think? They do cervical exams. So this is the uterus, okay? And then this is the cervix here, and the vagina is here. And this is all they do, okay? They feel, they compress the lower portion of your cervix, compressible, whether it's compressible. And what do you think? This is the Agues sign. You see what I'm doing? I'm trying to just make it easy. So compressible of the uterus, that's what they do. That's the H. So this is the uterus. They compress here and see if it's compressible. Yeah, if it's compressible, then fine. Then they look at the vagina and see if it's blue, the bluish mucosa. And what do you think? This is the Chadwick sign. And then if they're not satisfied, they go to the cervix, okay, and they look at the cervix also if he has a bluish discoloration, yeah, the cervical tip of it. Yeah, this is the Goodell sign. That's the cervix. And that's how you can remember these signs. They compress the lower part of the uterus, that's the Eagle sign, and then the Goodell is the cervix itself, and the Chadwick is the vagina, look bluish. This is the doctor trying to get information. To all this is due to blood flow to the area in anticipation for and delivery of the baby. Okay, and so that's what they do that. Then the last one is positive. Now that the doctor feel like 99% sure you may be pregnant, then they do a positive. Positive is like, not you, not the doctor. We want to prove that there's some baby inside there, some boy or girl lying here. I mean, I can see, I don't have microscope. I can look at this sign as my probable objective value based on what you tell me. But I got to see that there's some knot inside the uterus to show that there's a baby there. And so that's the positive sign. And how do you do that? This is why you use the ultrasound. I get to hear some baby screaming, heart rate. So fetal heart rate, they look for fetal tone, and then they visualize by ultrasound. So if you give you multiple choice or movement felt by the baby, by the doctor. So this is positive signs. They like confusing you, but it's easy. They'll give you a bunch of options. See which one the mother is doing it. See which one the doctor is doing it. That's it. Objective, probable. see which one is consistently, nobody is doing it, but it's something that is there. We've seen, everybody is seeing it. The ultrasound giving us information. Yeah, that's the positive sign. So that's giving you the positive, and that's how you can remember them. Okay. And that's the diagnosis of that. I know you pregnant. We know you're pregnant. So we do some few facts about OB. I like to talk about this first. So morning sickness. When you're pregnant, this is the first thing that start happening. Okay. And it's very common in the first trimester. It occurs all day. That's the trap question. If they give you, don't forget, it's all day. It's not in the morning, not in the evening. It's the all day problem. What do you do to the recommendation you give to the mother? Straightforward, small, frequent meal. It's like the GI symptoms. So if they're vomiting, yeah, they're losing fluid, I want you to hydrate yourself. So the more time you eat, the better. But don't eat too much so that your abdomen, your stomach get bigger and retain, and then you vomit. So I don't want you to do that. And then I want you to eat more frequently, right? But eating more frequently is fine. And I want the most common problem that causes this is fatty food. Why? It stay in your stomach for a long time. This is the problem people don't understand. Fats takes a long time to break down. So it stay in the stomach for a long time. So you should avoid it. Avoid fatty food, but have some carbohydrate. Okay. Some carbohydrate and protein so that you get nutrition and energy. This doesn't take a long time to be digested. Okay. And then some people recommend cold beverages, and that cool your gut down in between meals. That cool everything down and help with that. I've heard about ginger, ginger drink. You guys know more than me. And some nuts, something you can chew on, and that will prevent you from vomiting, and legumes. Why? Because they give you vitamin B5. They're very good. This is a misconception, and it does that also with reflux problem. Diarrhea products. If you see it, I'm just writing, putting asterisks there. Does not worsen the problem. So multiple choice, yeah, don't choose it. Everybody think dairy product is bad. No, it does not make you vomit more or not. So it's not a problem. You should not let that. That's a trap. Okay. So this is how you manage it. If it become really severe hyperemesis gravity, that one there, it turn into something different. It's a dehydration problem. We're not going there right now. This is the simple morning sickness. It's not a true HG problem now. Okay. Now, they want you to know how to calculate this. This is straightforward. I said short stuff that you're supposed to know. This is how you can, I call it the history of the pregnant lady. So it's an OB history. Everybody have a GT power. And you can see how many time G is the pregnancy total, how many they've had. It doesn't matter whether it's abortion, miscarriage, or term baby, it doesn't matter. So for us to be pregnant, you have to count it. Okay, then the T is 10. It depends on which book. I stay with 37. If you read it somewhere, you can stick with what you have. I stick with 37. And 37 week is a 10 baby. Some people will call 38. I say 37. Okay. And the preterm is between 20 and 37. So anybody between 20 and 37 is a preterm. And abortion is considered as anything below less than 20 weeks. And the R is any living child, whether it's term or preterm or anything like that. So you can calculate, it can give you a pregnant lady, is have 4 kids. So let me see, somebody have notes there before. Okay. Yeah. So we can make something up. I can give you like G4. That means she's been pregnant 4 times. So we can see what permutation we can have. Pregnant 4 times. If I give you 2 living, that's your clue that at least somebody have to be aborted. So there can be 2 has to be aborted. And I can give you 1 preterm. That means 1 has to be term. So these 4 pregnancies, 1 to term and is still alive, 1 preterm still alive. These 2 were aborted, so they are not alive. So you have this. You can fill in the gap. They can give you 5 T3, maybe A1, and then you can fill in the gap. If I give you A1, then you can figure out, okay, definitely if 1 is aborted, there should be 4 left. If 3 is term and 4 living, 1 has to be preterm, and that would make that. But they will give you in the sentence form, and you have to break it down in the straightforward form, and you can figure out what it means. These are bonus questions. You should not let it go away. But they will describe it in a language to confuse you, and you have to. They will say twins, Yeah, that's the thing. If I have twins, it's 1 pregnancy. You don't have 2 pregnancy for 1 twin. Okay, sorry. But when you're pregnant once and you can have 4 babies, quadruple inside you, it's still 1 pregnancy. So you can have G1, okay, and 1 term, and then the whole there's 4 living. That tell you these 4 babies were all term, and then 0 preterm and abortion. That is your clue. Since they have like 1 pregnancy, yeah, that means these are all quadruple. They were born once, but there's 4 of them up. So if they give you a twins, don't count it at 2 pregnancies. I think that's where they trap you from. Okay. Then they want you to calculate when the due date, and some guy, that's his name, he came up with something. So I'll just write it quickly. First day of your last menstrual period, and then subtract 3 months from it, and just had 7 days. That's all. Then you're done. Straightforward. If you know that this is all you need to know, they will give you the question and you fill in the gap, and then you calculate when the mother will be due. Okay. Weight gain. You have to know this. So weight. How much weight do you need to gain in pregnancy? The best way to know is to divide it. 18.5 pounds. So anybody under 18.5, this is 18.5 to 24.9. This is an ideal body weight. Okay, 25 to 29.9 and greater than 30 is obese. First trimester, it doesn't matter how much you weigh. We're all going to do the same thing. We have to gain the same amount of, so I put 1.1 to 4.4. Minimum 4.4. Minimum, you got to gain 1.1 pound a maximum 4.4. You can't go above this. Everybody, no matter which pathway you are, whether you're bigger, smaller, this is how much you're going to gain. Okay. And somebody didn't know the answer. Yeah. So this is where you're going to be, no matter who you are. So if you know like that, it's easy. Then the third and the second and third trimester, it depends on where you fall. Okay. It depends on where it is, the weight changes. So these who are underweight, you can think of it. They have to get 1 pound per week. Okay. They have to gain that so that they can do better. The second people, yeah, they gain 0.6 pound per week. And the third and the fourth, these two people, they just gain 0.5 per week. And that's how, because it's so complicated to know the way the pounds together. So if you break it them down, everybody gain 1.1 and to 4. Then the rest, the first one who are underweight will have to get 1 pound. And the second, the ideal body weight, just a 0.5, 0.6 pound per week. And then the rest, those who are more than ideal and obese will gain 0.5 because they shouldn't gain too much weight anymore at the second and third trimester. And depending on what they give you 55 weeks and the patient weight is somewhere, you can calculate whether it's consistent with that. Yeah, so somebody know the answer. Yeah, get it. Jenny, C as all the answers, you know. So that's the easy way. If you simplify it like that, these weight questions, I know it's confusing, can be annoying. And this one always confuse people. Me, sometimes it confuses. I have to step back and look at it. NST versus CST. What does that mean? It's look at the word I'm going to write. Non-stress. There is no stress testing. Do it like that and it will be easy, okay? The second one, start with the C, contraction, okay? Stress test. And if you do like that, you see that, oh, there shouldn't be stressed with this test. This test, I need to stress. And I'll put a table here like that, simple. There's 2 words that is going to be happening. Non-reactive and reactive. This is where they confuse you. The non-stress test, this is usually done to see if the baby is moving. That's all. Does the baby move? We want to make sure that the baby is moving, no problem. He's doing fine. He can tolerate anything. He's undergoing acceleration. That is good. That's what we want, right? And it's done at 28 weeks. At 28 weeks, you come in, and then we look for fetal heart and movement. That's all. We're checking for movement. All we want to do is we want to make sure the kid is what? Reactive. I want you to be reactive. So we want a positive test, positive, reactive. If the kid is negative, non-reactive, we have a problem. The kid is not moving. He's not reacting at all, no acceleration, then I don't like it. So for non-stress test, non-reactive is wrong, is bad. If it's reactive, it's good, right? That means you're reacting, you have acceleration. You're looking for fetal acceleration for at least 15 minutes. It can just keep on moving, jumping up and down. Yes, hey, we like you. So we like the baby who is moving, is reactive. For contraction stress test, I'm stressing you and you contracting. So this one, mommy come in and we stimulate the mommy. Okay, we cause the mommy to contract. We want to see if the baby can respond well with contraction during labor. That's what it is for. So we stimulate. We stimulate labor mechanism. So there's 2 ways. Either we will do a nipple stimulation, which will release oxytocin that will cause contraction, or we give you some to that, and that will cause contraction of the uterus. What do you think? If I'm contracting the uterus, I want the baby to tolerate it. I don't want the baby to do what? Causes deceleration. When the uterus is contracting, the problem it causes placenta insufficiency. That's a key. That if you understand that, you can apply it to giving medication to the mother. Every time the uterus contracts, there is a decreased blood flow to the baby. And when there's a decreased blood flow to the baby decelerates. I don't want this to happen. No deceleration. So I don't want what? Reactive. I don't want the kid to react to the deceleration. And that's the only thing that confuses people. A reactive form is bad. I would want non-reactive when I'm doing stress tests, because I'm looking for deceleration. If I see deceleration in the baby, that means it's a positive test. I don't want it. I want a negative test. That baby does not respond to the deceleration at all. And that's how you can find the difference between the two. And that's, if you see a question like that, that's what you're looking for. You're looking for no deceleration in the stress contraction stress test. In the non-stress test, I'm looking for reactive. That means acceleration. I want to look for acceleration. In the contraction test, I don't want to see any deceleration. So if I get a positive test, it's bad. Positive test means it's non-reassuring. And then those are the two things. You can find which way you can understand it. You can find it which way you understand it. Either you look for the positive or the acceleration, but please just have it in the back of your mind which way you want to think, because they can be confusing. So if I put non-stress test here and contraction stress test, reactive and non-reactive. Here, I want it to react. And this one, I don't want it to react. Contraction stress test, if I see reaction, is bad. Non-stress test, if I see non-reactive, is bad. So this is non-reactive. And this is the diagram you can draw to help you focus. Non-stress test, I want to see a reactive test, acceleration. I don't want to see no acceleration. In contraction test, I don't want to see deceleration. Okay, so that's why I choose here, non-reactive. And then you'll be fine with that kind of question, because they can be confusing. I know the way they will write it, you say, what are they talking about again? But that's what they're referring to. Just a few, if you see a multiple choice about maternal alpha fetoprotein, okay, this is usually drawn at 16 to 18 weeks. They like asking this, which condition is associated with it, okay? Easy way to remember, go down with syndrome, Down syndrome, okay? Down with Down syndrome. And then you increase with neurotube defect and trisomy 18. This is a quick way to remember, but you can, if you have another way to, but this is, they like asking that. In mommy, the draw alpha fetoprotein is down, is the level is low. Yeah, the baby is at risk for Down syndrome. If the baby is high, the level is high, yeah, neurotube defect. You should be looking for neurotube defect leading to that, or trisomy 18. Trisomy 18 is not feasible with life. You know, they usually will die very soon. But that's the way you should. Don't forget this alpha fetoprotein questions. They like asking that. Like older patient, they can ask you on a pregnancy, and it can be confusing because there's so many changes that happen. But I will list some of them Type the question. What is that? Oh, type the question. Okay, I'll type the question. So you can say, so the question will be like 36, or maybe, what is that? 20 weeks pregnant. Yeah, I mean, G1, P0, and present to OB clinic, and you draw alpha fetoprotein level. And they told, I forget the number, but they give you low AFP, which of the following is associated with this finding. And it will give you like trisomy 18. If they don't give you Down syndrome, I'm hoping they give you trisomy 13. Okay, which is the same as Down syndrome. Or they give you what is a neurotube defect. Neurotube defect disease or another problem, you know, they will ask you which one is associated with that. Yeah, it's trisomy 13, which is Down syndrome, a low level. If they give you high level, yeah, you got to choose the other one. So that's the way they will ask you. It said all the body system, things are going to change. And if you, those of you who've been, those of you who've been pregnant, you know, body system changes. The most prominent one is your cardiac. Your blood volume is so increased that the cardiac output increases. It's due to increase in blood volume. Okay, and then think about it. The baby is pushing on everything, you know, it pushes on your belly, raising everything at the bowel, is being squeezed. Yeah, GI symptom. What do you think? Constipation. Very, very common in the mother. So we tell them to drink 2 to 3 liters of water a day. Okay, some fiber, get 30 grams of fiber. And do some exercise. Okay, so GI symptoms, everything is decreased. What do you think about respiratory? Look at it. The diaphragm is being pushed up. The baby is basically going up, it pushing on the diaphragm, the mommy can breathe. Your lung capacity. If you don't know, there's certain words they may put it there, and then they may try to, they expect you to know. Okay, so this is going into the lung. This is one side. The volume of the lung is called total lung capacity. Most people is like 4 liters or something like that. That's how big is the lung. So when you breathe, all air go into it, and you fill your lung capacity. When the baby is keep on pushing on the diaphragm, your lung capacity decreases. You know, you go like that. It's very small, and so total lung capacity, you expect it to decrease. So this is it. Total lung capacity. That means the lung volume has gone down. So you see a question like that, that's what you're referring to. What do you think? Musculoskeletal. I'll put muscle skeletal here. And you see it in their belly, right? The rectus muscles, your six-pack start to separate. And you see the linea alba and linea nigra more prominent. You see a line going down like that. They separate, like they develop a hernia. Yeah. So there's separation of the rectus muscle to allow the baby, to grow. So that's what you see, separated like that. And the renal, you guys know that, right? They pee a lot. That's why they wake up. The bladder is being squeezed all the time. Any little urine in the bladder, your body say, empty me up, empty me up. So urine output is increased. And endocrine is very common. I mean, you should think about it. Pregnancy, you gain weight, everything start going up. And so what happened? You have insulin resistance. That's why they check your diabetes, make sure your sugar is okay. Insulin resistance, okay? Because of all the things you need, your metabolic rate goes up. And you can think about it depending on which question they give you. So everything start to goes up. Everything start ramp up. So endocrine system ramp up, the urinary system ramp up, the muscles start to separate, respiratory status start to go down, cardiac output increases, constipation, that's GI goes down. And then skin, you have a bunch of stuff for there. Okay, a lot of changes occur over there, right? You have the what do they call linear Niagara, right? Where I'll show you some picture, and the abstra in the abdomen, they have the erythema in the palm. All this is all due to the steroid sensitivity and acne formation. It's all due to that. And so you should be able to, like, depending on which question, some of the changes that occur physiologically, I'll show you a picture of it. Now, complication. Before that, the segue, let me see, complication. Blood pressure is always a problem. You don't know when a pregnant lady is actually hypotensive or not, but you have to know certain things. So in the first trimester, one trimester, the blood pressure is normal. It looks like anybody else. In the second trimester, expect it to decrease by 5 to 10 points. And that's why they always hypotensive. It's not like they in shock, but it's because it's naturally has decreased 5 to 10 points. And therefore, when you see a pregnant lady coming to you, they sick, they should never be in the supine position. Not good for them. Always left lateral. Let them lay on their side because they already hypotensive coming to you. If you let them lay on the supine, the blood pressure drop more. Physiologically, you think, oh, the blood pressure should go up because they have a lot of blood volume. I told you, cardiovascular system goes up. Guess what? The venous capacity is now great. Their veins are bigger. It can hold a lot of blood. And so even though their blood volume is increased, the cardiac output is increased, they don't have systematically, the venous system is more dilated, so the blood pressure drop more, so 5/10. So you want to put them in a left lateral, left decubal position if something happens. And that is something, concept you have to know. And this is what you apply to use whenever you have emergency in the labor and delivery. Yeah. And somebody said, somebody will say, well, how about if they're on the stretcher, you think they will fall? Yeah, take the stretcher. You can still take the stretcher, and then you can still get them in the lateral DQ position. Okay. Complication of pregnancy. They like asking. So after I think it's I'll finish this, then we take a break. An hour, I think we should take a break so that I don't want to stress you guys too much. Complication of pregnancy. The number one is I'm going to talk about hypertension. And to do that, I'll write certain word: chronic hypertension, gestational. It's better to understand them, then you know hypertension. And then you go to pre-eclampsia. Then you go to eclampsia. and you go to HERP syndrome. So these are things you have to know, but they can be a little bit confusing. So what is chronic hypertension? Somebody who is hypertensive, okay, he has systolic blood pressure greater than 140/90, and it's less than 20 weeks. So chronic hypertension means you have your blood pressure is greater, like stage 1 blood pressure, 140 systolic, right? And or 90 diastolic, and it was more than before 20 weeks. Before 20 weeks, you were pregnant, and you have this already, you have chronic hypertension. Okay. If it happened, new onset, so gestational, based on the name. Usually, if you don't know some stuff, scientists don't, they're very good. They're not very good. So they usually use names to make a diagnosis. So even if you don't know, it's a gestational. So it happened during you're pregnant. If this happened, and it has to be new onset, okay, new onset of hypertension that happened before, after 20 weeks, then this is what we describe gestational hypertension. By what? If you check their urine output and there's no protein, so negative protein, you have to prove that there's no protein there, or no signs of end organ damage. That is a diagnosis of gestational hypertension. If I have this, okay, so preeclampsia, so what does that mean? That means I still have new onset, right? And it's more than 20 weeks, right? And I have protein positive, or I have end organ damage. That's all. That is what preeclampsia is. So just break it down. Don't memorize it. If you have all these things, you have all the signs and symptoms of gestational hypertension, but at the same time, you have protein in your urine, or you have end organ damage. That means headache, photophobia, yeah, leg edema, yeah. That's a problem. And if I have this gestational hypertension symptoms plus preeclampsia, and in addition to that, I have seizure. And this has to be tonic, chronic seizure. Then I have it, eclampsia. So you have proteinuria, new onset hypertension greater than 20 weeks pregnant, and then all the end organs signs and symptoms with that, that's eclampsia. If then you develop nausea, vomit, and then right upper quadrant pain. And then when we check your lab work, you have what? Hemolysis. That means the blood breaking down, your LFT is elevated, and your platelet is low. Then you have HEP syndrome. This is the severe form of that. This is deadly. So you, as you can see, the deeper you go, the more likely you get deadlier. You know, this is okay. We get into trouble. You are in trouble. Be careful. You're seizing. Your brain is not thinking, and then you can go into shock, and you die. And so that's how pregnancy is bad. And so this is how you see this slide. It has a lot of topics in it, like, but in the compressed form, you try to make it easy, simple as much as possible. You don't have to, if they give you, see how many boxes you've checked. My blood pressure is greater than 20 weeks. I develop hypertension after 20 weeks. I have leg edema. You check my UA, there's protein. I have headache. Then all of a sudden I start developing nausea and vomit, and I have right upper quadrant pain. I have HEP syndrome. That's all. So that's the one major complication. The pregnant woman was to have a stroke. How do you manage permissive hypertension. So you have to have them on the drip. You have to have them on the calcium channel blockers to regulate the blood pressure. So you manage it the same way. Manage the blood pressure using the calcium channel blocker to ensure that you allow some form of hypertension. You don't drop it too low, and to allow brain blood to flow. Of course, there's a big problem. You worry about the kids too. So you got to balance both. That's why they have to be on a drip, and you can titrate it. So that is those information that you need to know when they ask you a question. Of course, this is a problem, and you have to know how to manage it. You know, you got to know how to manage it. The first thing is the pre-eclamptic patient, and then before they develop eclampsia, then help. So in the pre-eclampsia, it's a warning sign. I just call it a warning sign. They're telling you, I'm not ready. I'm going down here. You got to help me, okay? You want to prevent them from going to what? Eclampsia. Basically, that's the worst one. They start seizing. So these patients need to be admitted in the hospital, okay? They need to be placed on magnesium, which will slow down contraction. At the same time, it will lower the nervous system. So it decreases, it's a neuroprotective to the baby. Neuroprotective to the baby and the mother. So it decreases the nervous system overstimulation and allow you to recover from it. And then we have to monitor you. Of course, if you are on magnesium, certain things you have to do. Okay, you got to check the respiratory because it's going to decrease the respiratory rate. Okay, the urine output is going to change. You got to monitor it, and you got to see how much neurostimulation or depression you're causing. Yeah, deep tender reflex, all of this is going down. So we got to monitor it and improve it so that we can give them fluid and let them hydrate themselves. We check their respiratory status so that it doesn't go too low. If you go below 10, we are in trouble. If the deep tender reflex is going down like +1, I have a problem. So you have to be checking that. And so if depending on what question, these are the three things, if you know, no matter whether it's next generation or old one, no matter what kind of statement they will make, refer to these guys and say, is he part of it? Yeah. So this is the magnesium drip. Okay, you got to titrate it to that effect so that they don't go into seizure. As much if it's very, very severe and they become eclamptic, yeah, we got to deliver the baby out as soon as possible. Okay, and this is where there's a controversy. We don't have time for mommy to push. That's my understanding. If we have an emergency, we don't have time. Mommy push. We take a time for the cervix to ripe. The cervix does not just wake up and say, I want to be 100% effaced. You got to make sure you're 100% effaced. You got to be 10 centimeter dilated, okay? And your contraction has to be enough between 2 to 5 in 10 minutes to be able to push the baby, okay? And then mommy should be strong enough to do that. Somebody who has headache, he has hypertension, and then he's tired, he can go through all this drama. So C-section is your best answer. We got to bring the baby out as soon as possible so that we don't have a problem. The major complication for this is what? Hypertension is placenta abruption. You see, we don't want abruption of the placenta because of the high blood pressure. It will separate it from it. And so then we have two problems. You have eclamptic state and an abruption state. So that's the question I did this morning video so that you guys can know what you have to worry about. You have to think clinically. I need to prevent a big problem and I don't have time. So I don't want that situation. So I don't want abruption. So C-section. If they develop the same thing, right upper quadrant pain, then you are in worse trouble. Okay, if they develop right upper quadrant pain, yeah, and they have nausea, like I said, and vomit, then they've developed the HEP syndrome, which you will see that their platelet goes down. So when you check the lab, platelet is low, their LFT is high, their CBC, their hemoglobin is low. And this can also lead to abruption, okay, placenta abruption. And therefore, we want to deliver the baby quickly, as much as possible. They get a C-section, okay? We got to get it down as much as possible. Otherwise, the baby will be in trouble. Okay, so once again, I need to emphasize that. I want to just make sure you guys understand. If they give you a question, somebody on magnesium, don't forget your deep tender reflex is supposed to go down. Okay, the respiratory rate goes down. I'll just put 12 there so that you don't forget. But before you get to 10, you know that is wrong. So anything less than 12, the ascites will start to develop 95, and they will become somnolent. So those are the signs you're looking for. So I want you to be looking for these 4 things. Why is it so? And then if you watch my video this morning, I explain it. Magnesium and calcium, they're notorious. They cause this neural excitation, okay? But they go do it in a different way. If they are high, they lower neural excitation. If they're low, the excitation goes up. That's why when your calcium is low, you develop tetany, torsol signs, and chopstick signs. So that's the problem. And so because of that, when you put them on the drip, people don't think like that. If I put you on magnesium drip, I'm making you hypermagnesiemia. I'm increasing your magnesium. So all these things should be going downhill. But I don't want them to do that. Okay? I don't want this to happen. So these are what you're watching for, not to them to behave like that. Okay, I don't want this to happen. If it happens, we got to stop. And if it happen, well, they can ask you, what happened? If you start this, if you see this is happening, what do you think you should do? You got to stop your magnesium. Stop your magnesium drip. And give him his friend. His friend is, you got to protect the heart and the brain. So IV calcium. Okay. Okay, you got to do that. You got to protect them. So you got to stop it, give and then improve because you're stopping, you still have to follow them for seizure prophylaxis so that they don't do that. Okay, you got to be able to do that, all of them at once. Unfortunately, this is not the only problem that happen. They can become diabetic, right? And it's because of that, we saw the endocrine. I told you the endocrine, you develop insulin resistance. This is the reason why we got to check your glucose at 24 to 38 weeks. And this is just the screening test, the glucose tolerance test. That's the 1 hour one, where we give you 50 grams of sugar. You enjoy some high glucose level, and we check your lab weight. You don't need to no fasting here, okay? No fasting any time of the day. These are traps. So we just want to know, as you walk around, are you really, really diabetic, or your insulin resistance is too overwhelmed? You come in, we slam you with 50 grams of glucose, and we check your lab 1 hour later, okay? We don't need to fast anytime. The buzzword is 140, okay? 140, don't forget this number. If it's less than 140, you're good to go. I call it GTT, we're good to go. It's GTG, GTT is GTG if it's 140. You're good to go. You can leave. If it's greater than 140, we have a problem, not normal. And we have to do the 2 hours or the 3-hour test. Okay, this one, we want you to fast. Okay, we want you to fast. No caffeine, okay? It will stimulate too much stuff, and no tobacco. And we check the same thing, and if the number is high, you are in trouble. So 1, 2, 3 hours for and it has to be like greater than that. So that's the thing. If they give it to you, that's what they're referring to. Unfortunately, this is not that bad compared to hypertensive problem. And then I'm back to my friend, which when they ask you this, is just dehydration question. It's just dehydration. Don't tell me you don't know. You know it, okay? Upper emesis gravidarum. It's all he's telling you is we have passed morning sickness. We are not talking about morning sickness. You vomit to the point that there is systemic manifestation, okay, changes in your hemodynamics. It has affected your body system and you're in trouble. So we got to admit you in the hospital, give you IV fluid, okay? And we expect certain things you should know. It's a dehydration question. So what do you think? They have weight loss. You don't need to memorize. All the signs and symptoms you should expect. What does their skin look like? For skin tagger. What does their mouth look like? Dry, mucous memory, right? What do you, when you check their vitals, what do you think? Their heart rate is high. If you check their heart rate, they're tachycardia, right? The blood pressure, they're going to be more hypotensive, right? That is no surprise to you. And what do you think their potassium? They vomiting, this one I've talked about it all the time. They vomiting acid from their stomach. So they're vomiting acid. So they're losing H plus, they're losing sodium, they're losing chloride. The body will tell sodium, I need kidney, I need more sodium. And what does this kidney does? Lose potassium and hold on to sodium. So their potassium is low. Their sodium is still low, but they're trying to hold on to that. Their chloride is still low. What is their acid base? If I'm losing an acid, then I have to be metabolic. So we have metabolic alkalosis. What does their BUN look like? It's high. What does their creatinine look like? It's high. What do you think? Hematocrit, if you get it, or RBC, if you get it. What do you think? They dehydrated. These go up and up and up. RBC up. If I check your urine, I draw blood and I draw your urine. I look at your urine, it will look pungent, it will look dark. Okay, so they have dark urine. And then when you check it, what do you think? Urine specific gravity, you dehydrated, your kidney is sucking every fluid from it, is going to be high. So these are the way they're going to ask you a question. Trust me, this is like dehydration, and they will dig very deep. They'll try to see if you understand dehydration, and this is where you look. All these lab work, you have to understand where it's coming from and why it's causing all this problem. Urine specific gravity is going to be high. The urine will look dark. RBC will be high because it's concentration. If they don't write it, they will put hemo concentration. That's what it means. Hematocrit is high, tachycardia, hypotensive, all these lab work, and BUN creatinine is high. And that's dehydration. BUN creatinine is high because they dehydrated. When you dehydrated, the kidney, you go into renal failure. Signs of renal failure is high BUN and high creatinine. And so the glomerular filtration rate goes down. And that's why your creatinine goes up and your BUN also goes up. So it's a kidney function. So you have to know this. And guess what? This, if they give you pyloric stenosis, don't think twice. Pyloric stenosis. If they give you somebody is having NG tube for 4 days, it's the same thing. Pyloric stenosis, I have NG tube, I have hyperemesis gravida. We all going to look the same like that. In the same lab work, no surprise. Okay. Others don't like it. And so this is the linear Niagara, this is the line in the midline and the umbilicus, and you see these are all changes that occur with melanin and steroid level, and they have this line. Nobody marked them, but that's normal. Sometimes it goes away, some people still have it. And this one is in the face. It's the same as melasma or cholaxma. It's the same thing, but these are all steroid deposition and pigmentation in their face over here. This is all steroid associated with the kids moving around, allowing for the room. This is the abdominal strata with all the collagens separating from each other. And you see this stretch, baby stretches, they call it. This is different from that. This is what we call, it's different. It's not stria in the abdomen. This one is very interesting. It has a bunch of P's. So 1P, this is puperic, okay, urethrica, okay, and purple, a bunch of place of pregnancy. He has some fancy name. I call it the pop. Okay, that's the way to remember them. So puperic, that means it's a little bit itchy. It's uteric. You can scratch it. That's why it looked. And purple, you see flat line. It's not macular. A little bit raised. It's part of the pregnancy. This is not infectious. If you see it, it's not contact. You don't need to put the mommy on contact or anything like that. Let them wash it out and it'll be fine. It's no big deal. Okay, it's not infectious. They don't need an antibiotic or anything like that. But that's the name for it. Okay, it's a little bit itchy, so some lotion. You don't need the specific gestation. No, you don't need to know. It will just show up. They will just show you what you do with it. I mean, there's no, some people occur early, but most of them occur late, late trimester, getting after the beginning of the third trimester. Some people will show up in the ending of the second trimester because it's a chronic thing that has been happening for a long time. Yeah, but you don't need to know specific what time of the gestation would you see it. But this is some of the symptoms you see. The other one, let me see. I couldn't find a picture. But this one, I don't want you to forget that one. So they have intrahepatic cholestasis. It's very, very dangerous. It's like similar to HEP syndrome, but it's not the same pregnancy. This is straightforward, and it's a liver disease problem. It's dangerous. One of the, apart from HEP syndrome, I think this is the second one. But the presentation is very simple, okay? What happened is they will tell you, pregnant lady, third trimester with intense itching in the hands and feet. You think it's very benign. Be sharp moment. You have to intervene. That means they have stasis in the liver system, and you have to do something. They usually worse at night. Okay, but when you look at it, they have no rash. You can't find any rash in the body, in the skin, but the mommy is itchy like crap. What is the complication? Fetal demise. If you don't do anything, baby is going to die if you don't do anything. What is your treatment? You get an LFT right away, give them and check their bile acids, and then start monitoring the baby. Otherwise, they will die. And what do you do? Monitoring. Some of the things we talk about, not all of them. You do non-stress tests. You do biophysiological features of the baby, everything that you need, a profile that you need to know. Okay, you give them bile acid binder. Okay, that will bind all the bile acid, and then at 37 weeks, we induce labor. So you have to, like, even though it's an emergency, they don't need C-section right away, but you have to initiate, start monitoring the kid. Otherwise, if you don't do anything, they will die. So get the LFTs, give them some bile acid binder, do some stress tests on the kid and see if he's still alive, and then induce labor at 37 weeks. We can't wait any longer, but we want to get them to at least full term and deliver them. If you can't, you got to deliver them. But the idea is to try to get them to 37 weeks so that we can deliver. But if we cannot do that, yeah, we are in trouble. Okay, and this also like keep on popping up. GBS, Group B strep. Okay, it like coming up. This is normal in the vagina flora. It's normal. It's no harm, no problem. It doesn't cause any problem. But the baby doesn't like it. Okay? If you go into the baby, you get infected, you get a sepsis. So at 35 to 37 weeks, we check it. If it is positive, then we give you antibiotic before the baby shows up. Okay, those are the some of the complications, some of the things you have to know. But don't forget this intrahepatic cholestasis of the pregnancy. Very important. And then we switch gears. Some pharmacology. Okay. Pharmacology. There's only a few OB farms, you should know. This question. Yeah, somebody say some OB farm is, you know, I mean, very, very, they are not hard. OB farm is oxytocin or pitocin. What is it used for? To contract the uterus. And so it can be used to induce labor and augment it. Because it causes the uterus to contract. So if this is the uterus, you will contract it. You will contract the uterus to become smaller instead of becoming bigger. Think about it. If a patient is bleeding, postpartum hemorrhage, yeah, use it. You can contract it. to help with that. But it causes the uterus to contract, so you can develop what we call tachysystole if you're contracting too much. Okay, if you're contracting more than you need to. And how do you know that you're contracting more? This is normal, you have to know. 2 to 5 contraction in 10 minutes. That's good. I want you to stay there. If it's greater than this, we have a problem. And between each contraction, you have to know if there's one contraction, if I contract, before I can contract, I have to wait a certain amount, at least 2 minutes. That will give you this. So 2 minutes at least between each contraction. And how long does each contraction should last? No more than 90 seconds. So less than 90 seconds. If this doesn't satisfy, then you have tachysystole. You're contracting more than one contraction is greater than 90 seconds, and this time between each contraction is less than 2 minutes, and you're getting more than 5 contractions in 10 minutes, then this is giving you tachysystole. You got to stop the medication. What is the complication when he's doing that? Because it's deceleration and bradycardia. And I will explain. I need to take time to explain this. And you can use this information when they ask you what medication you're going to use, what time do you deliver it. You can use this idea, like to give a medication to a pregnant lady in contraction. When the mother is contracting, you get something like the beginning, apex, and end. When you start contracting, uterus is contracting, so blood supply start to decrease. At the apex, less flow of blood. And then when you go down, blood flow start increasing again. So at this point, there's no blood going to the placenta at all. So if I need to give you a narcotic, I'll give it to you here so that the baby doesn't get the narcotic when you go to the mother alone. So when do you give medication? At the peak of contraction. You see a multiple choice question like that? Peak of contraction, because there's less blood flow. Okay, and because there's less blood flow going to the baby, guess what? Baby doesn't like low placenta insufficiency. When you have placenta insufficiency, you get deceleration and bradycardia. You don't have to memorize. You see how that's why it makes sense. You get deceleration, you're going to get, it's because of contraction. And then, so when at the peak, the baby doesn't like it. You go there. So that's why you got to watch for those signs and symptoms for a patient on oxytocin. You should do that. Okay. This is something most people don't pay attention. I don't see people talk about it that much, but it's very good to know. In the multiple choice, that's what they're referring to. Oxytocin is the same, it has same ADH-like effect. So it acts like ADH. What does ADH do? Hold on to water, right? It's going to hold on to water. It absorbs water. Therefore, when the patient is on it, urine output is low. After you stop it, at the end, when they had a baby, this is why they go into urinary retention. This is the main reason why. They go on urinary retention now. All the fluid they be holding on to by the oxytocin, the pitocin, is no more there. And therefore, there's no more pitocin. So they have urine they need to get rid of. And they have to pee it out. So they have to pee it out. So you got to check their I&Os. Anybody getting pitocin need a folate and need an I&O. And then they will go into urinary retention. So you got to they'll develop water intoxication. Does that make sense? They will hold on to all the water until the pitocin is stopped. And after it's stopped, you got to pee them out and they will go into urinary retention. So
Excuse
water
me, sir. Can you
intoxication
bring your
is a
voice
side
up? I
effect of
cannot even hear what
pitocin.
you're saying.
Okay. Let me see. Question it. Typing. What is typing? I don't know. Okay, so that's the that portion of it. That's the first pharmacology. Then there's this guy, Mr. Presto. Very interesting. It's the same thing as cytotech.
Okay, that's it. That's not a problem. I'll do that. Thank you.
I can hear her, so cytotech. Cytotech is a prostaglandins, and is used to ripe the cervix. Okay, and to help with labor, it soften it. It can be given orally or through the vagina or the rectum. Okay, so these are the three places they can be given. Remember, because it can be given through the rectum, if they bleeding, postpartum hemorrhage, bleeding, don't put it there. Don't put in the vagina, put it in the rectum. That's so that it can go easily. You can get to the vagina easily. You don't have to let them take it orally or vagina. If they're bleeding, pitocin can be given in. Cytotech, give it through the rectum and you can get to the vagina easily and it will stop the issue. Okay. It stimulates contraction. But guess what? You have to know contraindication. That's what they like asking. Contraindication. When you should not use this. There's a reason why you should not use it. If they're already on pitocin, well, you have two things making you contract. If they have uterine surgery before, that will cause rupture. So if somebody have C-section, it does not mean you shouldn't get it. We got to talk about it. But if you have, because it causes contraction really badly, and you can have rupture. If the patient is having tachysystole already, we should not give it to you. Okay. This is the problem. Okay, this is used for somebody who has ulcer. If they have ulcer from NSAID, if I'm taking NSAID, Motrin, and I have ulcer, and I need this Motrin, I can't stop it. Then they will give you this, misoprostol, to protect you from getting ulcer. That is the key fact you have to know. But if the pregnant lady taking NSAID because they need to take it, whatever reason, they can't take it in third trimester, we want to prevent ulcer formation, we give them this, misoprostol. But guess what? This will lead to what? Abortion. And therefore, pregnant lady is in trouble. That's why, first of all, don't be taking NSAID. Because then if you need the NSAID, we have to give you misoprostol. That will lead to abortion. So we got to stop that. If it's not a pregnant patient, yeah, you can still give them misoprostol to protect the gastric lining and prevent that. The trap they give you is say, oh, okay, you can take antacid. You know me, I hate antacid. They cannot take magnesium antacid. It counteracts the effect. They can take calcium form of it, but not the magnesium. And you have to take it with food. Okay. But this is very important. If a pregnant lady is taking this misoprostol to prevent ulceration while it's on NSAID, they need to stop it because it's abortogenic. Let me see. So that's that one. Then this medication is what they use. This is the opioids they use all the time. The tophenol or Stadol, if you've seen it, or Nubian. They are all the same, or Nabu. I call it Nabu, but it's Nabufin. That's the. So these are medications you should know. These are all opiates. If they say give the patient opiate, this is the common one we give to patient all the time. It's narcotic. These are the common narcotic that is used in labor and delivery. Once again, it's narcotic. When do you deliver? Peak of contraction. So that the baby does not get it. Why? It causes respiratory depression. And so I don't want the baby to have it. Okay. That is very important. So that's when you want to give this medication at the peak of contraction. Mommy is contracting, then we give it to them. Then there's this they like giving all the time because but it's very dangerous, metagovernin. You have to know if you got to take your test, you have to know this medication by heart. It's used in labor. It causes what? Vasoconstriction. Guess what? Any medication that causes vasoconstriction can increase your blood pressure. And we hate blood pressure. We don't like a pregnant lady to be hypertensive, right? So when do we use it? Postpartum hemorrhage, when you're bleeding. That's when we use it. What do you think? I said it's used for vasoconstriction. Therefore, there is a contraindication. You should, this is what they like asking. If you already have hypertension, yeah, don't use it. And so this is what the nurse will do. The doctor will order metagovernin. Which of the following you should look for and question the order? A patient has a history of hypertension. No, we should not give it to them. Otherwise, they get into stroke or they develop seizures. Okay, so those are the things you should know. That medication is very, very good, but hypertensive patient, yeah, we cannot use it. We can use it with it because it causes too much side effect. Whenever we talk about labor, everybody is talking about contraction. You have to like there's some medication that does not cause contraction. And so if you know them, that's the question they will ask you. If somebody who is contracting is in preterm labor, you have to know what medication you use to stop contraction. And this is the common medication, terbutaline, that you have to know. This is also can be used in asthma patient. But what does it do? It's used for preterm labor. You stop it, slow it down, like magnesium. Okay, it suppresses contraction. Or somebody who has a tachysystole. If they ask you what medication you should use, you should choose something that will slow down. And this is one of the medications that slows down contraction, terbutaline. If you know them them it's easy. The answer choice is like straightforward. You should be able to recognize it. And then and we already talked about magnesium. Magnesium also slow things down. So you know that put them on magnesium, that will slow things down. and then prevent contraction. And then so preterm labor, you can use that. Okay, this is like a quick, dirty farm by highlighting all the medications that you can find in OB. There's not enough of them. I mean, but they're very important. If you know when to use them, yeah, you should be fine. Something we have to talk about. So less than 20 weeks, there's few of them. It's either miscarriage, but the normal one that they like is ectopic pregnancy. And then most of the time it happens before 20 weeks, you know. And the classic presentation now with the next generation, pay attention to these keywords. I'm going to say keywords. So it's the first trimester, okay? So early, 20 weeks, right? Patient comes in, the pregnancy test is positive, ECG is positive, right? And what? Unilateral, one side. Unilateral, what? Ground pain. It cannot be two. You can't have, unless you have two ectopic pregnancy, but odds are very, really low that you're going to have two ectopic pregnancy. And they have vaginal spotting. So ground pain and spotting. This is ectopic pregnancy until proven otherwise. Of course, you got to rule out appendicitis. Okay. But with the pregnancy test, yeah, it's unlikely. The appendicitis, what do you think? It has to be right lower quadrant. So if the pain is on the left, there's no way it's going to be appendicitis. By the examiner, guess what? They put it on the right side so that you can distinguish between this and the appendicitis. By female, G1, P0, first trimester, ECG positive, unilateral groin pain, and some spotting is ectopic pregnancy, proving otherwise. And what would they have here to tell you is ectopic pregnancy? They have to be a referred pain to the shoulder. So whatever side they're bleeding, they're having issue with, it will go to the shoulder. So they have shoulder pain, either the left side or the right. So it's a referred pain to the shoulder. This is an emergency. We got to take patient to surgery, but that should not be your number one answer. They're in shock. What is the problem? This is a B-sharp moment. It's a shock problem. You can't take a shock patient to surgery. So what is your priority? If they ask you what is the next priority, it's not surgery. The next priority is not surgery. Okay, we know we got to take the patients to surgery. But I need to make sure they have IV fluid or they have an IV, they get in some blood. You basically tanking them. You filling them with gas before they go and evacuate the gas out in the surgery. They're going to be in shock. If you intubate them, they die. So being transfused, IV fluid, IV access, type and cross and type and screen and everything. They have their Foley. Of course, we need to let the surgeon know we're going, but we need to prepare them and make sure they have everything ready to take the stress of the surgery. So prepare them for those eventuality that is going to come, and then they will be very, very successful. Okay, so that is the most important thing you need to do. They need to have surgery, but you got to prepare them, have an IV fluid, everything, because hemorrhage is the problem. And the risk factor for this is smoking. Smoking is the risk factor. So that's ectopic pregnancy. Apart from that, 20 weeks, less than 20 weeks pregnant, it's usually miscarriage. You know, it's just painful problem. Okay, it's just painful. The cause is unknown. We don't know what it is. Okay, if you have one before, yeah, so you have high risks. What do you do, the nurse? There's nothing you can do. All you need to do is support them, supportive care, and be nice. But you got to teach them and be frank. No sex for at least 2 weeks, okay? If you use tampon, sorry, none. We don't using it for a while, okay? Because if you do that, then you go into shock. Let all the bleeding go away and everything, and then when everything subsides, then you can come in. They need to start taking their prenatal vitamin and then some pain medication. That's all. That's all you need to do for them. But it's a sad story, but you got to just help them and educate them to know what to expect when you go back. Any question? I don't see any question, so you guys got it. Let's see. And I think that's the 20 weeks, quick ones. After 20 weeks, I try to make it easy as much as possible. You have to know certain things. The mommy is they're going to see some blood, okay? They're going to see some blood. They will see small amount of blood, think mucus. And this is their blood show, okay? When you're ready to have a baby, that's normal. That's not bad. That's okay, you know. But they have to have some contraction with that. So a little bit of intermittent contraction with some blood things, this thing, yeah, that's sure. But apart from that, we have a couple of things we have to do. We have abruption, we have eruption, okay, we have a previa, oh, yeah. Rupture, we have a previa, now we have an Accreta. These are what causes some bleeding after 20 weeks. And then you have to know the difference between them. How do you distinguish between them? It's very important that you have to know which one it is. So the key for this kind of question is buzzwords. Buzzwords. You see it, you don't change your mind. You said, no, I know this is it. So we do the Previa, placenta Previa. Okay. All it means is this is the uterus. The placenta usually stay here like that. It's not completely attached. This is some small fibers, but it's not completely buried when it goes to the baby. Unfortunately, in a Previa, this is the cervix. It goes here and cover the cervix. I don't know why you want to do that. You're telling the baby, you're not coming out. I'm a policeman. I'm covering it. So you can see, if you put your hand there, you poke it. You put the placenta, bleeding. If the baby contract, you push on the placenta. It's a bleeding. So it's a problem. It's just the abnormal implantation. That's the way I remember it. Implantation of the placenta to the cervical os, basically, in the wrong place. And so it can cause bleeding. It can impede blood flow to the placenta as it contract. So the risk is what? Hemorrhage. You'll have hemorrhage. If you see this, mommy cannot contract. There's no way you can induce labor here. You get placenta insufficiency. So if we need to take this lady to surgery, or we want to deliver the baby, you have to make sure that you don't induce any labor before 36 weeks. And most of them will need C-section. But sometimes we're lucky. The cervix, the placenta will move away. And we'll be able to salvage it. And so how do they present? It's painless. They don't have any pain. Painless bleeding. They have painless bleeding through the vagina. It's bright red blood. There's no pain. And then when you get an ultrasound, you see that. You don't have to do anything. Patient has to be admitted, rest the pelvis. That means nothing go there. No sex, okay? No vaginal exams. Absolutely no. You see where the cervix, if you put your hand there, you poke in that. And then you monitor them. If you get better, they go home. And they come in at 37 weeks, and then we take care of them. We don't want them to come in before they already start contracting. If they do that, they're going to cause problem with the placenta. If he doesn't move, yeah, they get C-section. If he moves, they're able to deliver. But the key word is painless vaginal bleeding. With the ultrasound, you see the placenta and the cervical os. You avoid any vaginal exams. They shouldn't be having any sex. They should rest their pelvis. You should admit them, see if they do well. If they do well, let them go home, come back before they start contraction and induce labor. If not, we do C-section. Okay, so that's the placenta previa, right? Placenta previa. Okay, let me see. Now, his friend is Accreta. Accreta said, well, me, I'm not just getting, it's like kissing the uterus. I'm going to get myself embedded in it. That's all. That's what it means. He just get himself. If this is the uterus, the placenta is buried in the wall to the baby. Guess what? This is not coming out. So this is not coming out at all. Even when the baby gets delivered, this will cause postpartum hemorrhage. This is the one most of the time they need C-section, no matter what. But what is the most important thing? You may not be able to deliver it, and they may need hysterectomy, total abdominal hysterectomy. So you have to tell the mother, consent them for hysterectomy. But the most important thing, when they're going for surgery, you know there's going to be bleeding. Therefore, you, the nurse, if they ask you a question, make sure they are type and cross. They have blood available. They have IV, getting IV infusion already. You check their CBC, you check their coags, everything ready in case they start bleeding. Yeah, so this is the more important than the surgery itself. You prepare them for any eventuality. Okay, and that is painful bleeding. Now, you already know about placenta abruption based on the name, abruption. So there is painful, it's dark, bleeding. The uterus is going to be rigid. The kid is not going to like it. They're going to have D-cell. And this one, yes. Emergency, emergency, emergency. We got to deliver the baby with C-section. And the same thing, have all the blood available, type and cross the mother. They need to know they may need the uterus, all those things you got to tell them so that they are aware. But this is how you can recognize abruption, deliver the baby as soon as possible. This is my favorite, but it's not my favorite because the answer choice is straightforward. Uterine rupture. And the key thing is the lady will be on labor and delivery in labor, pushing all of a sudden, lost of fetal station. We don't know where the baby is. We can't find. Where did he go? Did he enter into the abdomen? Yeah. Loss of fetal station, hypotension of the mother, fetal deceleration. You may lose tone completely. Yeah, loss of fetal station. That is the key, that we can't find a baby. And this is, and then another buzzword, if the uterine is ruptured, what do you think? Cessation of contraction. You look at a monitor, there's no contraction anymore. Yes, I have a rupture. Labor I'm in labor and I'm pushing, and all of a sudden, boom, I can't find the baby. We can't listen to the baby. There's no contraction. I have what? Uterine rupture. This is emergency. Another emergency. Go to surgery as soon as possible, and then have your blood, the same thing, because it's going to be bleeding. Have everything available that will help you have be successful. So resuscitation, I keep on emphasizing it because this is what I do. Surgeon. Sorry guys, I gotta tell you, I don't like talking about it, but we don't take anybody to surgery without being resuscitated. Anesthesia itself can put them into shock and they will code. So we got to tank they fill them with fluid first. Then we go, then evacuate whatever we want to do. But you have to do that. Okay. So those are the 4 things you should be able to know. In the buzzwords I give you. Unfortunately, sometimes they bring this guy into it, Uterine Atony. Okay. Which there's no surprise, okay? He's tired. He doesn't want to contract anymore. So it cannot go down. It cannot, after the uterus, everything is supposed to go down. It does not. It does not. It remains the same. And this is the thing you have to know. If this is the ischial spine and this is the umbilicus, when the baby is delivered, okay, if you start at 20 centimeters here, the uterus is supposed to descend 1 centimeter, okay, per day. It's supposed to go down 1 centimeter per day after you had your baby. So you can calculate. This is 12 centimeters. Okay, so you're supposed to descend every centimeter per day. So if they tell you maybe mommy delivered 5 days and the uterus is still at the umbilicus, it's supposed to go down every centimeter. So atonic, that means it's not going down and it's not looking what it's supposed to do. This is normal. If you know normal, you can find abnormal. I want my uterus, sorry, not me, but sorry. I want the uterus to be firm. It has to be firm. Okay, that's what a mommy would say. It has to be contracted. Okay, it has to be midline. And it has to be below the umbilicus. These 4 things, if none of them satisfy and you see it in the question, is wrong. So firm uterus is good. Contracted is good. It's in the midline is good. And it's below the umbilicus is good. After the baby, that's where we want it to be. I want it to be. If anything like different from this, if it's soft, we have a problem. If it's buggy, we have a problem. If it's displaced, we have a problem. All these signs will lead to bleeding because you have uterine atony. So when they give you a question and it does not look like that, you have to look for the signs and say, something is wrong. That means the mommy is going to be bleeding. So we got to cause the uterus to be firm, make it contract, keep it in the midline, and make sure it's going down. And what do? You just massage it. Massage it as much as possible. And then if it's displaced, push it in the middle. If it's displaced to the left or right, it's because of the bladder. The bladder is here. The bladder will push it. So we'll put the Foley in. So we put the Foley so that we can bring it to the midline, like we said. And then we monitor how much Lochia they discharging. That means they're bleeding, and we have to take care of it. If none of them is happening, we got to give them medication to contract. So we'll give them like a pitocin to help you contract to prevent hemorrhage. So that's how to manage the uterine atony as much as possible. Okay, so briefly, sorry. Let me see, what do we have in the next slide? Okay, so this is a quick labor and delivery stuff. I think I start talking about some of them already. But just we'll go over them briefly. They want you to understand the difference between true labor versus force. This is another easy question. You should not let it go away. I'll give you one side and know one side, and then you compare it to the other side. When do you know a lady is in true labor? If it's the true labor, there's 4 things you should watch. Look at the quality of the contraction. Look at the mommy discomfort. Okay, what does she do to take care of the discomfort? So I would say comfort measures. And then look at the cervix. What happened to the cervix? Does it change? If you are in true labor, your contraction, it has to be regular, okay? Keywords, buzzwords, right? The frequency also has to be regular. Duration has to be regular. And they have to keep on increasing over time. You see, it does not have to remain the same. The regular, but keep on increasing as you go. Okay. Then, where should the contraction start? Start from your back, lower back, and it has to go into your abdomen. What should you do to take away the pain? Nothing. Nothing you will do will help with that. No matter what you do, the pain is not going away. And when you look at the cervix, there should be effacement, and the size, it has to dilate, changes. If any of this doesn't happen, it's a forced labor. Straightforward. That's the way you should look at it. If they describe it, they say, oh, it's regular every 2 seconds, every 2 minutes, and they keep on increasing, going up and down. It's regular, yes. I have to check 1. Did mommy do anything to help with it? It took some medication, it never helped. Good, check 2. Right? And where does the pain start? From the lower back to the abdomen. Check 3. And we look at the cervix, there's changes to the cervix in terms of size and effacement. Yeah, that's it. But if there's no cervical change, the contraction is lessened by doing something, by walking, positioning yourself, or doing something. Or the pain starts with the lower back, but the lower abdomen, it doesn't go anywhere. Or this is irregular, it's a forced labor. Once again, 4 things you should pay attention to: contraction, discomfort, whether measures you did help with that, and if the cervix changes. These are your key for force and true labor. That's all. That's what I will say about that. Force and true labor. These are how you can distinguish, because they will give you statement and say which one is true, which one is false. Yeah, somebody say D3C. Yeah, discomfort, contraction, comfort, and cervical change. I like that. D3C. You know. Okay, before we go this, I got to give you the terms. Okay. I think I already said it. There's key things you have to know um, about labor. Okay, it's divided into 3 stages. There's a latent stage, there's an active stage, and then you have the stage 2 and then stage 3. So this is stage 1, stage 2, stage 3. The stage 1 has the active and the latent stage. You don't need to bore down too much about how much. I mean, I think you can figure out how much dilated they are or something like that. But you have to know the latent is the preparation. When you get into active, there's nothing stopping it. Okay, nothing stopping. We got to go quickly. So that's why the latent stage. But you can just know that the latent, I usually use how much they dilated, like 0 to 3 centimeters. That's all. As soon as the path start to 4 centimeters, I consider them in active stage of labor. They're going downhill. Okay. And they can go all the way to 10 centimeters. That's what I use for that. And then, there's some books they will go into effacement. It doesn't matter. When they give you a question, I don't think they will bother you. But just know from 0 to 7, 3 is latent. After 4 to 7, they are inactive. But the second stage is we already complete dilation and effacement. So when they give you patient is 100 centimeters and is 10 centimeters, you know they are in second stage of labor. And then this is go to the delivery of the baby. Okay, stage 3 is where you deliver the placenta. And then stage 4, usually the last one. That is 4 hours after delivery of the placenta. But I want you to pay attention to the first portion because that's where the question usually they try to say so many things, you don't know what they're talking about. Stage 1, you are within 0 to 10 centimeters. The active stage is 4 to 10 centimeters. After that, complete effacement and dilation, you're in second stage to the delivery of your baby. And then placenta is 3 and 4. What I want you to know is the contraction, because that's what certain things you have to know so that you can read it straight. Duration. We talk about it. The duration of each contraction should be less than 90 seconds. One word. I'm not going to disturb you too much about it to confuse you. Frequency. How often should they do that? 2 to 5 in 10 minutes. That means they should contract like what? In 10 minutes. If they're contracting 2, so that means 1 at least. They have to like between 5 contractions. So every 2 minutes, you should have 1 contraction. That is the best way to remember it. The intensity, how strong should it be? It should not be greater than 80. That's the intensity of the contraction. Otherwise, they get into trouble. And those are the 3 things I wanted to pay attention to. Sometimes they ask you about the resting tone. These are very, very common, this thing. And so we're going to look at it. If you're contracting more than 2 to 5, we have a problem. Yeah, so let me see. So let's see. Clean this. Now, to be able to read the strip, you look at it. The lower one belongs to the mother. The upper one is the baby. And this is showing you the contraction. It goes up and down. Then there's a relaxation, contraction. Then you see what happened. There is a corresponding. So you draw a line from here. What happened to the baby when the mommy contract? What happened to the baby? That's what you're looking for. And so when they give you a strip, first look down here and see how many contraction. This strip is 10 minutes. Okay, you can see and you can calculate. You can calculate from here. This 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So 10 minutes, and I have only 2 contractions. So that is good. They're always going to give you the 10 minutes. So 2 contractions in 10 minutes. That's good, right? Then you look. If you don't even have to look the duration. If you look from here to here, this is less than 90 seconds. So that's good. It doesn't take a long time. It's less than 90 seconds, so it doesn't take too much a long time. There's a scale. I don't see the scale, but it will tell you how much the scale, right? It doesn't take a long time. Then you look at the baby, how he's doing. What is the resting heart rate? If you can't read at all, you can look at it. This is the heart rate, and the baby is at what? 150. And he go up and down around 150. That means, look, is very moderate variability. We want it to be go up and down. We don't want the heart rate to be flat. We want it to go up and down, up and down, up and down. So that's good. Then you look at it, what happened to, so I say, oh, baby is good. He has moderate variability. Then you look at the peak of contraction or at the beginning of contraction, what happened to the baby? When mommy contract, nothing to happen to the baby. At the peak, there's no deceleration, and a little bit of acceleration. Then when the mommy is going down, everything looks fine. The same thing, no contraction, baby is happy. He's having acceleration. Here, you see some acceleration with it. So that's good. So this rhythm is good. Mommy is contracting 2 every 10 minutes, and the baby is chilling. He is having acceleration. He's happy. There's no problem with the baby. So this is a good strip, just by looking at it. Okay, it's a good strip from it. Compared to that, look at it. How many contractions do we have? 3. So 3 in 10 minutes. So that's good. This is not more than 90 minutes. So that's good. From here to here, it's almost 2 minutes. So that's good. Then we look at the baby. What is baseline? It starts from, I think, 130. So that's his baseline here, or 140. Then we said from beginning of the contraction, you draw a line going here. Then as the contraction goes up, look at what the baby is doing. It starts to go down. At the peak of contraction, it's all the way down. So when mommy start contracting, baby start going down. You have to learn how to recognize the theme. I start contraction, baby start going down. So this is early deceleration. I start contraction, baby going down. I start going up, baby going, I start going down, baby going up. So this is what we call early deceleration. It's not, the baby doesn't go down after the mommy has contracted or at the peak. So this is early problem. You can see baby goes down at very early stage of that. So this is early deceleration. And this is not good. This is where you have to learn your the V-chop, because that's where the question is going to be. Where V is a variable deceleration, E is the early deceleration, A is acceleration, L is the late. And when you have a V, you have this. You have chord compression. When you have a E, you have what? Head compression. When you have a A, it's okay. And when you have a L, you have a placenta problem. So you have to know this to use the, because that's where the question is going to be. So the V-chop, and you can figure out what you need to do based on signs and symptoms of that. Okay, so variable deceleration, cord compression, or prolapse, I don't like it. We have a problem. Early deceleration, yeah, I mean, it's head compression, it's okay. We can move the mommy around a little bit. Acceleration, I'm chilling. And late deceleration, placenta is not happy. So I have to be not good. That's where you start thinking about your lion or placing the lateral position. Anyone that is bad, like late deceleration, lateral as an IV fluid, oxygen, and be ready to go notify the MD and take the patient to the OR. Treatment, lion. Lateral cube, make sure they have an IV fluid, IV line, they're getting oxygen, and we're ready for surgery. And that's placenta insufficiency. Okay. Let me see comment. So that's the treatment in a one slide and what you do for both of these conditions. You should be able to recognize what you need to do for each condition and everything. So left lateral D cube, okay, IV fluid, oxygen, and notify the MD to go to surgery, especially placenta insufficiency. We have to do that. If they're on Pitocin, we got to stop it. If they're on Pitocin with placenta insufficiency, and you see late decel, yeah, or variable, we got to stop it and then put the mommy in a different position. Okay. This is where confuse people. If it's a variable deceleration, yeah, this one is more dangerous than the late deceleration. In variable, we put the mommy in a knee chest compression position and stop the treatment. If I never said it before. So variable deceleration is knee chest position. Stop whatever medication we're having and then stop the contraction. Okay. Terbutaline is what you use to stop the contraction and then get ready for C-section. Get ready for C-section. Variable decel is more dangerous. So knee to chest position, stop the Pitocin, give them terbutaline to slow it down, and let's go to surgery as much as possible. Okay, so that's the treatment. Don't forget, don't confuse that one. Variable versus a late deceleration. It's a different problem. Okay, that one is a cord problem, cord compression. If we compressing the cord, I mean, it's not good. And so let's look the other strips and you see what you have. Let's see if you can recognize it. What do you guys think? Look at this one. So this is a late deceleration, like you guys see. Once again, look at how many contractions you have. We have 3. Okay, that's over 10. That's fine. And this is no less than, is no more than 90 seconds. And this is almost greater than, this is 1 centimeter, 1 minute, 2 minutes. So we have 1 minute, 2 minutes. So it's good. We're perfect. Mommy is fine. But what is the problem? We look at what the baby is doing. Mommy start contracting. Then you draw a line. If you can't see, draw a line. If in the test, draw a line on the computer. It's not on the computer, but use your hand on it and see, where am I going? And then you see, you trace this. Nothing is happening to the baby. But as soon as you get to the peak, the baby is going down. So there's nothing here. All of a sudden, then boom, it comes down. When the mommy finished, the baby is still going, start going up. This is the late deceleration. And you already know. It's a what? Placenta insufficiency The next question will be, what do you do? Lie on and treat them out. The same thing. So this is a passing level kind of question. Make a diagnosis, know your treatment, and then be able to read the strip, make a diagnosis, and treat the mother. Okay. So I put them all together. There's this one, if they ask you, you look at it, it doesn't follow any pattern, you know? It's like oxygen saturation. This is sinusoidal rhythm. This is the worst one. It's bad. It's fetal demand. This is hemolysis. That means something. There's bleeding going on. There's a RH positivity mixing or some hemolysis happening here. We have to do something. This one is the dangerous one. So sinusoidal rhythm is not good. We hate it. Okay. And I put all of them together for you, and you can see what is happening. If you look at it, mommy contract here, boom, boom, boom. Then when it contract, what happened? When I contract, look at this guy. He follow mommy's pattern. They do the same thing. Mommy stop, fine. Contract, he say, oh yeah, I also contract. Contract, I also contract. This is what? Acceleration. So I'm good here. What happened to the second one? Mommy contract, baby start going down. At the peak, mommy is up, baby is down. The same thing. It's opposite to what the mommy is doing. So this is what? Early deceleration. Look at this one. At the peak, that's when the baby starts going down. At the peak, baby going down. This is late deceleration. This is the dangerous one. Look at it. At the peak, nothing happened to the baby. Peak, nothing happened to the baby. When a mommy doesn't contract, that's when the kid is going down. So there's no pattern. Look at here. There's nothing happening. But the baby is going down. This is what we call variable. So there's no relationship, variable deceleration, no relationship with the contraction and fetal heart tracing and with the deceleration. This is why it's bad. You can't determine, you don't know. You can't predict when the baby heart rate is going to drop. That's why it's called variable deceleration. That's why it's very, very dangerous. There's no correlation at all to the contraction and fetal heart. So it's dangerous. We can't monitor it. We can't do anything. We can. How do I know? And so that's why we got to like deliver the baby quickly. You put them in the knee to chest position, give them terbutaline, and then the doctor get them ready for C-section. Okay. And that is OB. I think I want to talk about something a little before, then we can where can I go? I guess yeah. Postpartum. We have to do that, otherwise. Postpartum. What time is it? Oh shit, it's 2:00. Yeah. Postpartum hemorrhage. That means mommy is bleeding. Something is bleeding. Okay, something is bleeding, and there's causes for it. Okay, there's several causes for that. You have to know how to manage it, because they can ask you in a next generation question and what you need to do and how to monitor it. Okay, the primary cause form is it happened less than 24 hours after baby, and if it's secondary is after 24 hours. Okay, you have to know what is bleeding and what is not bleeding. So Lochia is what comes out, you know that. And there's different. There's ruba that's red, and there is serosa, that's yellow pinkish color, and aba is white. Okay, these are the stages is undergo. You have to know the stages. That's how you can tell if the patient is bleeding. Rubra is usually you can have between 3 to 4 days, and it's dark. Okay. Then after 4 to 10 days, you have the serosa. Okay, which is pink. They start to see some pink color. Then after the 11 days, these dates are very specific. Okay, they start to see white or yellow. So when you're educating them, you ask them, they have 3 days and they have dark, yeah, it's expected. 3 days and then 5 days, you see dark blood still coming out. Yeah, we have a problem. Okay. 11 days, you see still dark blood. Yeah, 11 days, I expect some white lochia coming out. And if that's happening, yeah, I got to tell you, you're bleeding. So that's one sign. Second sign is look at the way they stated, soaking of the pads. They won't tell you, but if it's being saturated, okay, less than an hour, we have a problem. This is a priority, bleeding. Examiner will not tell you. Like they said, the lady is changing the pads less than an hour or every hour. That's a problem. We're bleeding. And so those are your signs of postpartum hemorrhage. Okay, postpartum hemorrhage. There's a definition. Okay, if you 500 cc through vaginal delivery is bleeding. 100 cc with a C-section, that's bleeding. So somebody have an undergo C-section and they have 100 cc of 1,000 cc of loci, yeah, then you know they're bleeding. If it's 500, then vaginal bleeding. What are the risk factors or common causes? Okay, what do you think? What are the risks? Who are risks of postpartum hemorrhage? If you had it before, prior episode, yeah, you're going to have it. The way I distinguish it is the size of the uterus and how it contracts. So one, urine size. If you did something to your uterus and it's bigger than normal, do you if you really what did they call it? If you what did they call prior episode? If you have prior episode, oh sorry. If you have prior episode of this problem, you have a problem. And then the urine size, the uterine size. I try to pay attention. That's the only thing I try to, because I don't want to memorize it. So if I have to increase the size of my uterus, then I have a problem. And what are the conditions that would do that? Multiple gestation. Yeah, we have a problem. If you have a lot of babies, so quadruple, 5 babies inside there, 3 babies, more likely. If there's a lot of fluid in the uterus, polyhydramnia, that's another problem. That means too much amniotic fluid. Yeah, you expect to see postpartum hemorrhage. If you have a big baby, my first son, he was like 10 pounds. Mommy was in trouble. That's like really bad, you know. So microsomia, they're so huge, you know. Yeah, you know, and there's a definition. This one I memorized it long time ago because of my kid. 8 pounds greater than 13 ounces, yes, or you greater than 400 grams. That's a tiny baby, but still for the uterus, it's huge. So these are risk factors. They're doing something to the uterus to make it bigger. If you have prior episode, your uterus is so big because you have multiple gestation or the too much amniotic fluid, or the baby is just huge. It doesn't want to come out. It stayed there for a long time. The third one is, like I said, I try to break it into small segments for me to understand. It's what happens at labor if the uterus get fatigued. So if you give them too much Pitoxin, they get tired. Okay, so if you have urinary atony, it's going to also bleed. It's not going the uterus not to involate. Remember, go back to what I said. I want the uterus to be contracted in the midline, okay, after delivery and below the umbilicus. So you want that, and it shouldn't be boggy. So well, if it's fatigued, it's going to be boggy. If you give it to Pitocin, it will contract and it get tired. All these things is a problem. Okay, so we don't want that. Or if I give you too much what magnesium, you will slow down. Too much terbutaline, yeah. All this will slow it down. So these are risk factors for what? Postpartum hemorrhage. If they give it to you, they will give you a bunch of answer choice. Think about it and think if does this lead to urine relaxation, too much atony or fatigue? Does this increase urine size? Or you've had that one before? Those are the three categories, and then the rest is history. There's something here. So yes, okay. So that's that. Then one more thing, then we go to the other listening, I think. Shoulder. Stop here. This they like asking because it's dangerous. How would you know that this is a problem? You have a fetal head that coming, but and it comes out, okay? It comes out, it doesn't stay, it just go back and forth. The head retract. It retract back. And the description they will tell you is it's a turtle sign. They may not say it, but you see the head, then it's snake back like a tortoise. You see them, they poke their head out, they smiling at you, then they move back. That's a turtle sign. It remain in the pubic symphysis. It's a problem. Okay, what is your number one? They will describe it. They say the baby head is coming, but when it comes out, then it goes in and out, in and out, in and out. Number one next. What would you do? What do you think is number one? Number one thing you should do is to look for the time of onset, because time is not your friend now. I know I say your test time is your friend, but for this particular problem, mommy does not have time. Time is not your friend. I need to know the time is happening, because the longer it happens, we have a fetal what? Dysphagia. And the baby is going to get into trouble. Okay. And you have a nastic brain injury. So we have to deliver the baby. After 33 minutes, 5 minutes, we are in trouble. We can't allow the baby to asphyxiate for more than 5 minutes. And we have a problem. So time is your problem. And we got to fix that time by delivering the baby as much as possible. So in the bow tie question, they will ask you, if you see that, what is your number one action time? Secondly, what you do? You got to prevent the turtles from going back. That's my plan. Turtles, you're not going back. And how do you do that? That's this guy, he shows you, Mark Rabbit. Okay, he's the one that came out with the plan to help with the tortoise from going back, Mark Rabbit, right? So you bring the mommy, okay, the leg towards the abdomen, okay, abdomen. So you can say knee to chest, close to, but knee to abdomen, okay. and then counter contraction. Okay, when the mommy is contracting, the baby is coming, you put counter contraction on the suprapubic area. You apply pressure so that the baby can retract. You just push it, stay there, so that your head stay out. So knee to the abdomen and your hand on the suprapubic. Don't forget this, because that's what they're going to ask you, because it's the dangerous. You have to know maneuver, how to save the baby, okay, from this total sign. So we got to prevent the head from going. So you put a pressure in the suprapubic, but the leg has to come up and towards the abdomen. And that's what, then don't panic, okay? This is the problem, you don't panic. We got to deliver the baby, but you have to document the time, and then we can take care of this problem easily. You have to count, and you have to make sure we don't lose that time. So that's the main thing you have to do. Okay, any question on that? Because that's very, very important. And then sometimes they bring this kind of question. I don't know, but I'll try if I can make justice to it. It's hard to explain to people, but I'll try if I can explain to you guys. So you may already know it already. So there's presentation of the baby. Okay, so this is the pubic, and the spine is here like that. There's presentation in the pelvis. Okay, I'll just do it like that. And this is the mommy back. Okay, this is the spine. So this is divided into different segments. So this, if the mommy is facing me, this is the left side, and this is the right side. So mommy is facing me with the legs out. Yeah. So when the baby is coming, there's different position. Okay, there's different position. You want the baby to have what? Present with anterior position instead of the posterior. So anterior occipital. So I'll write it. I don't know. I'll try and do justice to it, because sometimes it's hard to explain it, but you have to do it. Let me take this one. So right occiput posterior. So the right side, so right. When you see something like the right occiput posterior, the right is the mother. The occiput is the baby head, so the baby back side. Okay, and the posterior, right? The occiput at the back side pushing on the baby also. That's the baby is attaching to the posterior aspect of that. So the posterior to is the baby. Right. So occiput. So that means the baby is using the back of their head, okay, pushing on the mommy side. So and then they are attaching the back side of the mother side. Does that make sense? So that's the problem. Okay, so the right of the mother, occipitus, and the posterior of the mother, but they're using the back side. So if I make the mother, that may help you. So the occipitus of the mother. So most of the time, we will want them to attach their back side. So their occipital anterior. That means their back side is attaching to the anterior aspect of the mother. So this is the anterior, that's the front. It can be left or right. Whenever they do the back side, posterior is a problem. So if I give you like LOA, then you know this is left side of the mother. The kid is occipital, that's this back head is attaching to the anterior portion of the mother, that's the front. This is good. Or the right side of the mother, baby is using the back of their head to attach the anterior side of this. These are all good presentation. If they present with the posterior aspect. The posterior aspect is pushing on the occipital is pushing on the back side of the mother. This is not good. Or they can have left occipital posterior. This is not good. Or this they can change the LOT. That's here. LOT is here. ROT is here. Okay. All these things are bad. If it's anterior occipital or occipital anterior, occipital and either left and right, these are good presentation. Like I said, you have to look at diagram but this is the easy way to show you which presentation. This, if the baby, the right, that means on the right side of the mother, right? And the baby is using the back of their head, push on the mommy's posterior, that means mommy's spine. You should expect the mommy to have really bad back pain. This is what they would describe it in the question. Bad back pain. If they're having bad back pain here because the baby is pushing on the backside, yeah, you got to apply pressure there to help with that. But best presentation is occipital anterior, and it can be left or right. Okay, I hope that makes sense. It's hard to explain. You got to look at the diagram and then look at it. Okay, what time is it? It's 2 o'clock. So just I'll try and do justice to this quickly. Neonatal facts, and I'll show you before, you can look at the bubble health. That's postpartum, what you need to do for a pregnant lady. Briefly, yeah, I guess I got to say for a complete sake. Whenever the baby is delivered, we got to do this for the mommy. You have to check on them, okay? If they're on postpartum, after it's delivered, check for their breast, okay? They're doing the right, the latching, the breast get engorged. You look for the uterus, make sure it's descending as much as possible, okay? Check their bowel, make sure they pooping, okay? Make bladder, make sure they voiding. If they have urinary retention, put the Foley. I told you about pitocin ADH effect. And then we saw the loci. It makes sure we're going from roba to serosa and to the white, okay? And the changes are occurring appropriately at the same time. If they have episiotomy, be sure we're taking care of it. It's not red, it's not inflamed, and the way to remember is REDA, okay? All those signs. So it's not red, there's no edema, there's no ecchymosis, there's no drainage, and it approximated well. Once again, REDA for episiotomy. There's no redness, there's no edema, there's no ecchymosis, there's no drainage, and it's well approximated. Okay, you do a rectal exams, make sure the hemorrhage is not too huge. It's supposed to be huge, but not that bad. Okay, you check their emotional status. Okay, make sure everything is okay, and they get their rubella if never get it. You check their rubella status. Otherwise, they'll get pregnant again, and then they won't have it. And then you give them their vaccination. So quick, something you do at postpartum management. And that's what the question will be. Yeah, somebody say any P is bad, any, yeah, so that's summary for that for you. So that's the bubble, this thing. Okay, neonatal facts. Okay, I'm back. So this one, I have another video in YouTube. You can look at it, but I just want to be brief. Infant neonatal fact. Not everything. Time is fast spent. But you can watch another one. But just a quick fact that they like to ask. Respiratory rate, is between 30 to 60. And then there's 20, basically, you should not see any nasal flaring. If you see that, it's not normal in a kid, right? If you see retraction, it's not normal. Those are all abnormal signs that you should pay attention to. You should know how to assess a kid. And the way they will ask it is a little bit, they don't tell you, but that's what they're looking for. They say, which of these will you do when you see a kid coming to the clinic? How do you assess them? The order of assessment. I call it look, okay? You look at it. So anything that you get to do and you look, that's observation. So you observe them. Try to observe them and get information. Look at their color, the activity. What are they doing? How are they active, looking at their mom, interaction with their mommy. Those are all way to examine them. And you can look at their respiratory pattern just by looking how are they breathing. You don't even have to listen. So first one. Then second, you listen. Because if you don't follow this pattern, you miss the opportunity to examine them. When they start crying, you can't do anything anymore. So after you look, now you can listen. You listen to their lungs and their heart, okay, and their bowel sounds, okay. So that will give you some information from them before you start palpating. So for the least aggressive to more aggressive, now you can palpate things. Palpate and percuss. So the abdomen, you can do that. You can poke in the abdomen, the fontanelle, and look if it's still there. Okay. And then you can look at your high exams. This is a little more invasive because now you're looking and palpating and you're probing before you do a moral reflex, where you throw them down and feel like they raise both their hands and their legs up, like they're trying somebody to support them. This is the stages of that. You can't pick the kid and all of a sudden you do a reflex test. Wrong. You can't just palpate the abdomen all of the time. They get mad. So look at them first. If they give you enough information, listen. After you've listened, now you get to be aggressive, palpate. If they let you do that, then you drop them. But don't drop them first. Otherwise, you lose the opportunity to do any of them. Okay, you will lose the opportunity to do any of them at all. You can't do anything after that. Like I said, there's some facts, quick facts that we'll talk about, and we can do some questions. Most of the thing you can find some in my videos. The questions they like, I know I've been asked multiple times, is join this. Okay. It's just 24 hours versus greater than 24 hours. Any kid that is yellow, okay? If you yellow before 24 hours, we have a problem. Bad. This is pathological. That's what we call it. It's straightforward, but they like asking questions about it. So just know, if I see a kid within 24 hours, it's a pathological problem. Either they bleeding from ABO incompatibility, there's like hemorrhage occurring, and you have to do something because blood, when it breaks down, it releases hemoglobin, and hemoglobin has bilirubin. And if your bilirubin goes up more than 15, you have a brain problem. This is why connectors, we don't make sure hemoglobin doesn't go more than 15 in this case. And we have to treat them with phototherapy. So we treat them with phototherapy to destroy that. Okay. And when you are undergoing phototherapy, you know what to do. The kid is hot like crap. They put him in the radiant. Okay. The whole body is exposed. And then we cover their eyes and their genitalia area. Those are the areas we cover. You can still give them breast milk. Okay, don't starve them. They have to be getting IV fluid because of the heat, and still giving them fluid. And you monitor how much diaper they give you. Wet diaper is telling you they're pooping, okay? And you have to apply lotion to their body and other things, but you have to continue to hydrate them as much as possible. If the jaundice is more than, is after 24 hours, yeah, that's physiologic. It's not pathological. It's due to like basically either feeding problem or other stuff, but usually it's not a problem. We take care of it. We monitor that. Okay. You know, their heart rate is usually not normal for other people. This is 160 for them. They give you a question. When they cry, you can go to 180. That's all normal. Okay. And in their respiratory rate, I told you they are like 30 to 60. They usually have a pause about 20. They pause like 20 seconds. They can do that. That's fine with them. Okay. There's some features, skin lesions that you should pay attention, and some reflexes. Okay, some reflexes that you may have to know. The Moro reflex, okay, which we talk about it. You drop the kidney, raise both leg up, and they start on movement. These go away after 3 to 6 months. Okay, just go away. When they're born, the labia is swollen. It's all estrogen. Or they can have a white discharge. That's normal. Don't worry. It go away after the first week. Their fontanelle, you have to know. There's anterior and then posterior. And you have to know when each of them is going to close and when the other one is closed, and what they look like. The posterior one is usually diamond shape. Okay. No, the posterior one is smaller shape, so it's a triangular shape. Okay, it's posterior one. So it's triangular and it's smaller. And it closed by 2 months. The anterior one is bigger, and that's why it's a diamond. It's a diamond shape. And that takes a while. It takes like 18 months to close. So if I see a 15-month-old kid with the anterior fontanelle, yeah, I shouldn't be worried because I know it takes 18 months to close. I'm going to show you some pictures, and then because that's what I think some people were asking. Yeah, there's this lanugo. This is the same thing you see in anorexia patient. Why? And this is for kids who are preterm. Okay, preterm. They're inside the mommy, they're preterm, so they don't have ability to control their heat. And so when they come out, they have a hair to protect them. It's a primitive finding to protect their body. Guess what? Anorexic people, the same thing. They're more nourished to the point that they need to protect themselves, warm themselves up so they can develop this sign. So that when you see that in anorexic patient, yeah, Linugo is classic for them. Okay, it's very classic. And so don't worry. That's normal finding in the preterm kids. That's not a problem at all. The other thing too is their hands and feet can be blue. So hands can spare. And feet can be blue. This acrokinosis. What do you do? skin to skin. Just give the baby to the mother, and it's going to warm him up, and it will be fine. That's fine. That's not a problem. In a preterm baby, if they give you a question and they tell you about their testicles, they like that. It's fine. It's undescended. That's okay. Our testicles, not you. But if there's a male there, the testicles start at the back of the on your back. It's where the kidney is. Where you see where the kidney, you have two kidney. Yeah, the testicles and kidney are bodies. But then it will descend into the scrotum here because of the body temperature. You need to go here. It needs some temperature to be lower than the body to be able to make semen. So that's why. But it actually start from here and come all the way down out of the body. But the vessels are still from there. You can trace the gonadal vessels all the way. They run together with the kidney. And so they all the way to the back. But the testicles is outside to allow temperature for the sperm formation. And so when you are premature, you never had the time to descend all the way. You should expect it in the groin area. Don't freak out. Undescended testicles in the kid, in the premature, it's fine. The risk is testicular cancer. So we have to give them time and it will descend. If it doesn't descend, later on we'll do surgery and bring it down. Okay, so that some of the things you should, let me see if there's a question. I see another question. Okay. So that's normal in the preterm baby. So don't freak out or anything like that. Okay. Then there's the cord. We saw the placenta. So the cord, there should be what? Two what? Artery, I got them 2A and IV. Every cord should have two artery and one what? Vein. If it's opposite, there's a problem. You have a kidney issue. That's all. Just know the cord of the baby should have a two artery and one vein. When it's one of them of each, it's a kidney issue, heart problem. You should get an ultrasound to check their heart. Then what did they like asking, like vitamin K. Okay, we need vitamin K to improve our blood, coagulation factors. That's what coumadin bind and other thing. This is already low. The kid intestines, most of your vitamin K is made in the intestines. There's bacteria there. We have a bacteria that helps us make vitamin K. And then we exchange. It's symbiotic relationship. They lack this bacteria. So the kid is not grown, therefore is going to have low vitamin K. Guess what? Breast milk also have low vitamin K. And vitamin K does not cross these four things you have to know. Does not cross the placenta either. Why? Therefore, we need to give kids vitamin K. This is why we give them shots. They don't have the bacteria. The breast milk they're going to get is very low, and it doesn't cross the placenta. So we need to give them vitamin K shots. This is the main reason why we give them vitamin K shots.